welcome back to the Only You podcast. I'm Barbara Schulte, a psychiatric nurse practitioner, and we are joined by Dr. Amezcua-Patino. Welcome back. Today we are going to be talking about a somewhat sensitive subject, talking about hospitalizing children and adolescents and how to know when to do that. Thank you for joining us today.
Thank you, Barbie. I think this is going to be an interesting process and podcast. As you said, this is a very sensitive issue.
Yeah.
Probably one of the most frightening experiences for a parent.
Yeah,
the idea
absolutely.
of having to have your child go into a psychiatric hospital brings all kinds of fears and concerns and ideas about what it was like 100 years ago, and they're going to go into places where there's crazy people and so on. I have to tell you that hospitalization over the last 30 years in psychiatry has changed a lot.
Yes.
Psychiatric hospitals back when I started training in the early 80s, mid-80s, and before was a rehabilitative process. Patients used to go into the hospital, not unusually for 30, 60 days to deal with their depression, sadness, suicidal thoughts, psychosis, whatever, right?
Yeah.
That doesn't happen anymore. Things have evolved in a way in that psychiatric hospitals have become like what I like to call them the psychiatric ICU, the intensive care units. And a lot of other services are developed around that. Yeah. And in my experience, usually one of three things lead to a child coming to the hospital. And I'm not going to talk about diagnosis, just in general, usually psychosis,
Right.
behavior that is danger to themselves, or behavior that is danger to others.
Okay.
Very rarely any other of those situations will get you into the hospital. Sometimes, and with adolescents in particular, we don't see it as much, detoxification from certain drugs, right?
Okay.
So that will be the fourth one, but that's a minor one. Most of the patients that you and I see in the hospital are usually there because they're trying to hurt themselves, they're thinking about hurting somebody else, or they're suffering from distorted thinking or psychosis. So usually patients will show up somewhere else and not to the psychiatric hospital.
Yeah.
The process usually happens that, let me give you an example of a patient I hospitalized this morning. 16 years old, is in school and tried to hang herself in the bathroom, right?
Yeah.
She didn't succeed. She has a history of depression and anxiety. She has been hospitalized before. The family gets contacted by the school. The paramedics get called, and she ends up in the emergency room.
Okay.
She's evaluated medically in the emergency room. In the emergency room, technically they should offer the family and the patient an assessment and options in terms of what treatment can be provided. Most of the time nowadays, a case like that will be referred to a psychiatric hospital. So what happens when the patient gets to the psychiatric hospital? Another assessment happens to determine if the patient needs to be in a psychiatric hospital. A discussion has to happen with the parents, and technically the parents should be offered options. In the state of Arizona in particular, every child has to have a guardian. We quite rarely will find an emancipated child in Arizona because Arizona doesn't have traditional emancipation laws.
Yeah.
So we have to have a parent that is going to participate in the process. Sometimes the parent is the state, right? So Child Protective Services or Department of Child Services will be involved in situations like that. So the patient comes in, and eventually, within the first 24 hours, will be evaluated by either you or me. We're going to see the patient, and we're going to determine if the patient, again, needs to be in the hospital and initiate treatment.
Right.
That's where it gets a little complicated, right?
Yes.
Because people have different ideas of
What treatment means. What does that entail? What does it look like when the patient is receiving treatment?
Well, when the patient comes in and gets evaluated, we have a treatment team, right? So most people think that, well, the doctor is going to do something magical and things are going to change. No. My team consists of a number of different people. So we have myself, we have nurse practitioners, we have physician assistants, social workers, nurses, therapists that work with the patients in groups. So our whole team is going to get together to say, well, what is the situation that led to this crisis? And what are the steps that we need to take for the patient to be less of a risk?
Yeah.
So a lot of what happens in the acute inpatient side is the determination of risk. And let me tell you why I'm saying this. Especially when it comes to suicidal behavior. Suicidal behavior is not an illness that can be treated with a pill.
Mm-hmm.
It is a behavior that is risky that could lead to the patient dying.
Yeah.
So our job in the treatment team process is to determine how much of a risk does that patient have of becoming deaf by
Yes.
going in a non-secure environment.
Correct.
So we're basically doing a determination of risk and initiation of treatment.
Correct.
Why do I say initiation of treatment? Because, for example, if the patient suffers from major depression, okay, with all the symptoms of lack of energy, lack of motivation, lack of interest, irritability, feelings of hopelessness and helplessness, and feel suicidal, we have to initiate some sort of medication most likely. But the medication is going to take 3 to 6 weeks to work effectively. So the fact that we start the medication is not going to reduce the symptoms to a point that the patient is going to be totally safe. So we initiate some therapy, okay, and we initiate some family consultation to determine what is going to be the next step that is going to lead to decreased risk. So I always like to use the analogy of a heart attack, right? You get a heart attack, you go to the ICU, right? They treat you, they determine what caused the heart attack, what kind of interventions do we have to have.
Yeah.
And then the wife of the patient comes and tells you, okay, is my husband going to have another heart attack? And you have to say, well, I don't know.
Yeah.
But I know that your husband is at risk of having another heart attack because he already had one.
Yeah.
So I can tell the parents, I can tell you for sure that your kid is a higher risk of suicidal behavior because he's had suicidal behavior before, because he's got depression, because he has substance abuse, because the family is dysfunctional, because dad suffers from alcoholism, right? So what are the things that I need to do or that you all need to do
Together.
to bring that risk down? So if it was a heart attack, I would say, well, you need to lose weight, you need to exercise, you need to stop drinking and smoking,
Yes.
right? So if those things happen over time, you're going to have less and less risk. The same thing happens when we're doing it with suicidal behavior or homicidal behavior. So that means that we have to provide them with tools so they can reduce the risk of that happening again, right?
Absolutely. When you're looking and evaluating the family unit or where the patient came from, how are you evaluating the risk, let's say? Because it is, a patient attempting suicide, self-harm behaviors, it typically doesn't come out of nowhere. A lot of these patients have struggled for a long time, and when they end up in our facility, it's typically a breaking point.
Every single aspect of the individual's life, whether it's a child, an adolescent, or an adult, is going to have an impact on the determination of risk. So we evaluate the individual circumstances, we evaluate the biological circumstances, and we evaluate the social circumstances. Each one of those is going to have a component of risk, right? So if you're talking about specifically of the family, we want to know, how strong is the family unit? Is the family unit together? Are there issues in the family unit that are problematic, right? Are there issues in terms of drug and alcohol abuse in the family? Is there a history of neglect? Is there a history of abuse? All of those factors are going to play a role. But also we have to look at the individual factors of the child. For example, if the child has neurodevelopmental issues, the kid has attention deficit disorder that is quite severe. The patient has impulse control issues. The patient has oppositional defiant behavior. So those are individual risk factors, and we have family risk factors, and then we have psychologically developmental factors. What kind of personality is the child developing? And all of that you were talking about didn't happen by accident.
Mm-hmm.
So I like to say that during the assessment, in my mind, I'm trying to picture the movie.
Mm-hmm.
What does the movie of this child looks like from the time the child was born to now, right? And what are the things that we need to do to make the next chapter of the movie less risky?
Yeah.
Right? So when I talk to my students, that's the way I say, you're going to present a case to me. I want to present it to me like you're talking about a movie. So I can picture in my head, how did this patient get here? So we see kids that are very traumatized, that have sustained severe abuse, neglect, that were exposed to drugs in utero, who have had both physical and sexual abuse, who have been abandoned by their parents and they're under the care of the state, right? So that part of the movie is terribly important in the determination of risk. It's not just what happened now, right? It's the extension of the movie and what are the interventions that we need to create so that the next chapter of the movie looks a little nicer.
Right.
Right? That's not the case for most kids. I mean, we have kids who have never had depression before, have very intact families, who actually have severe depression, and they feel so helpless that they thought that life wasn't worth living. And then we have a very strong support system, which decreases the risk. There's no substance abuse. The kids are enrolled in school. They're in a protective social environment. So that makes it easier, right?
Right.
We use the analogy of the heart attack. We already have someone who was doing exercise, who already was trying to lose weight, who's not drinking alcohol.
Yeah.
Hey, the risk is lower. Right?
Yeah.
So there's it takes a village, right? Everybody has a component participation on reducing the risk. It becomes a little more complicated when you're dealing with the danger to others' behavior, right?
Yes.
Because you have an interaction of the potential hurt of other people. And sometimes you have the legal system involved, right? So the legal system can be of a lot of help on reducing risk or can be a hindrance on reducing risk, right?
Yeah.
Because it depends on the flexibility they have to accommodate rehabilitation versus punishment, if you may.
Right.
Right. But I think that we have developed good relationships with those systems and trying to always think of what is in the best interest of the child. Now, here's where it becomes problematic sometimes. The best interest of the child is not always what the child wants.
Yes.
Right?
And how do you work around that?
Well, you have to have a strong support systems and you have to have a strong guardians, right? And there's been a significant change in society, right, into believing that children and adolescents should have a full vote and voice on decision making, right? And I like to say that children and adolescents are still dependent on the judgment of other people for the choices available to them.
Of course.
So nowadays is that parents, I think, your age, I want to criticize millennials, and you're going to tell me that I'm a boomer.
Okay, boomer.
Okay, boomer. Okay, so the reality is that your generation has become afraid of their kids. And there's been a lot of helicopter parenting, putting kids in boxes, and kind of a negative advocacy for the children, right? I mean, let me give you an example. In my time, and I'm an old boomer, okay? In my time, and I hate to say this, but in my time, if I did something wrong in school, right, and I get home, my parents would probably tell me, you did something wrong and you deserved it. Nowadays, we have parents that go and fight with the school.
Oh, okay.
Because the child got punished, right? So that ends the communication between systems, right?
Oh, okay.
Into the role of the parent is to protect them from everything, including other authority figures.
Okay.
So there needs to be some balance, right, into acknowledging that our children are imperfect, that sometimes our kids are mischievous, and sometimes they deserve to be punished.
Correct.
I mean, I'm not saying punishment in a
Punitive,
negative, abusive,
right.
punitive way. I'm saying they have to confront the consequences of their behavior,
Correct.
right? That's not happening a lot.
Kids are very entitled now.
Exactly. So they're not only entitled, but I think that they feel entitled to the excessive protection of their parents.
Mm-hmm.
And that leads to immaturity,
Mm-hmm.
right? So we're creating generations of kids that are terribly smart intellectually and terribly immature emotionally.
Mm.
So they think it's adults, and then they throw tantrums like 3-year-olds,
Yep.
right? So that's not something we have seen before very much, and it's happening more. And it happens in the context of the kid being in the hospital, in which the kid feels entitled to the parents protecting him in the hospital, right? So very often, some of the issues, not frequently, but often we have to deal with parents perceiving the hospital as part of the problem instead of perceiving the hospital as part of the solution.
I think also because, like you said, that they're intellectually very intelligent, that they are, again, entitled to that part of the opinion, that they are part of the treatment plan because they are the patient.
Correct.
But again, forgetting that they are a child.
Yes, and kids hate me for this because I say it very often when I talk to them about their rights.
You
know?
don't have any.
Well, I say that they have, actually, I think the children and adolescents have 5 rights. They have the right to have a place to live,
Mm-hmm.
to be clothed properly, to be fed, to not be abused, and to be educated.
Mm-hmm.
Outside of those 5 rights, everything is a responsibility,
Mm-hmm.
right? Now, tell me how many parents believe that.
It's not even that the parents don't believe that. I think sometimes when we meet with the parents and we remind them that they are parents, they get, I don't know your experience, but I know when I meet with parents and I remind them that they are the parents, they get kind of happy. They get excited, that they, I'm an authority figure to my child? Oh, okay. And then the kid is like, oh, okay. And then obviously the patient gets upset, but the parent gets very happy and excited that they have power over their child again. Like they have never had that before.
Well, I think that empowers the parents, one, to be parents, second, to feel that they're not alone on taking some risks. And I think a lot of parenting is risk taking, right? Is to not allow your kid to make mistakes and allow your kid to get hurt sometimes,
Right.
and not to protect your kids from any emotional pain.
Yeah.
And I think that in part is because the newer generations have not dealt with pain as much as older generations. And I mean, I see patients now who are in their 30s who've never sustained a loss in their life.
Mm-hmm.
Nobody's died.
Yeah.
If you look at a family in the 1940s and 50s, they probably had 12 kids, and by the time the oldest was 18, 3 have died.
Mm-hmm.
So losing and grieving was part of life. Now grieving is something to avoid.
Mm-hmm.
And we have to learn to grieve again. We have to learn that pain is not, it doesn't have to be the end of the world.
Mm-hmm.
Because the vulnerability of our kids makes them more prone to make bad choices, right? So we're not developing very strong societies. And this is very first world. This is not something you're going to see very much in Central America and Africa, where
Right.
kids don't have an option, but they're forced to grow up, which brings all kinds of other situations.
Right.
Yeah.
Right. So again, going back to the hospitalization, just kind of wrapping it all back together. Length of stay, about how long are you seeing kids in the hospital?
Well, I mean, most kids will be in the hospital between 5 to 7 days.
Mm-hmm.
In that time is enough time to make things develop a treatment plan, giving the parents and the child options into the things that need to happen for the kid to be safe outside of a hospital. I don't think that kids should stay in the hospital very long. The psychiatric hospitals are not equipped anymore for long-term stays. Now, of course, we have residential facilities for the kids that require long-term stays, and you know more about those than I do because you have to deal with those kids every day. But basically, there are facilities where kids go in and stay there for anywhere from 30 days to 6 months, depending on their needs. So there are options for certain kids, but that's more the exception than the rule. I would say most kids, I would say 90% of our kids get discharged home to intensive outpatient treatment and better services.
Any final thoughts on inpatient psychiatric care for adolescents, children? Any major thoughts?
I really would like to tell the parents in particular to ask questions, to be advocates for their kids in a healthy way, and to become part of the process of rehabilitation. Do not be afraid of their kids, because I think that their fear empowers the children to be dysfunctional. And it's not an easy thing to do. It's not an easy thing to make decisions when you're afraid. But communication with your treatment team becomes probably the best tool to facilitate rehabilitation in the long term.
Awesome. Thank you guys very much.